Hi, this is Dr. Poole, and this presentation will cover acute leukemias, AML and ALL. This has been helped along with material from Dr. Miller in our Department of Pathology, so thanks to him. Okay, let's start off with the basics, some definitions. And what do we mean by acute leukemias versus chronic leukemias? So these are terms that are used to classify lymphoid and myeloid proliferative diseases. These terms are persistent terminology from older classifications, but it's important to realize that the term acute does not always mean clinically acute, and what it actually refers to is those leukemias that are composed of immature precursor cells. These cells are rapidly dividing. These are usually aggressive neoplasms, and so the patient is usually quite sick. Just as a caveat, acute has nothing to do in this case with acute inflammation, in which we have the mature myeloid cells, neutrophils. Now in this presentation I'll cover acute myeloid leukemia, or AML, which is a proliferation of immature myeloid blasts. There are a couple high-yield exceptions, including acute promyelocytic leukemia and acute monocytic leukemia, which I will also cover. But all of these are lumped under the general term AML. In contrast, there's acute lymphoblastic leukemia, and these are lymphoid neoplasms that are composed of precursor B or T cells. And for various reasons I'll explain in a bit, we usually call these leukemia lymphomas, leukemia/lymphoma, and they're all lumped together under ALL. Now, if you're wondering what chronic is and just can't stand waiting for the next presentation on chronic leukemia, chronic refers to lymphoid neoplasms, and only one entity has the term chronic and leukemia in it, and that's chronic lymphocytic leukemia/small lymphocytic lymphoma. Now, there are many other neoplasms of mature B cells, that is, B cells that express surface immunoglobulin like normal mature B cells, as well as T cells that do not have the word chronic in their name. Now, we can group these together as being low grade, which means that they behave in a somewhat indolent chronic manner usually. However, some of these neoplasms that are composed of mature lymphocytes do behave in a more clinically aggressive manner. By the way, morphologically, we use the term mature to refer to those lymphoid cells that have a more condensed chromatin pattern that we see in normal small mature B and T lymphocytes. And usually when we talk about mature leukemias or lymphomas, that usually means that they're low grade. Okay, let's return to myeloid disorders. So we can group myeloid disorders into AML, chronic myeloproliferative neoplasms, or MPNs, and then there's a third category called myelodysplastic syndromes. And I'm not going to talk about much of this in detail. You'll notice if you're using PATHO, that myelodysplastic syndrome isn't even mentioned at all. And so it's not really a high-yield concept. It's a difficult area, and so just kind of parenthetically mentioning it. But this is how we would group myeloid neoplastic disorders in general. Now, this diagram shows the relationship between these three different entities. Now, in most cases, the majority of patients with acute myeloid leukemia have been previously healthy, and they spontaneously develop genetic abnormalities that drive the AML. Now, there are some patients that have undergone some kind of genotoxic chemotherapy, and as I'll mention in an upcoming slide, these makes patients receiving genotoxic chemotherapy are at risk for developing AML as a side effect. If you look under myeloproliferative neoplasms, these entities myeloproliferative neoplasms are sort of analogous to chronic leukemias, and they have the potential of developing into AML. Now, in between these entities are these myelodysplastic syndromes, and they used to be known as pre-leukemia, which I think nicely encapsulated what their relationship is. Now, when we talk about solid tumors in upcoming cases, sometimes we talk about pre-malignant conditions or in situ carcinomas that can develop into more aggressive, more malignant neoplasms, and this is kind of where myelodysplastic syndromes fit in. So the old name pre-leukemia actually, I think, accurately described their relationship, and that there is some kind of stem cell abnormality that is latent within the cells, and they have the potential to develop into AML. In fact, I think the British historically called these smoldering leukemia, and that is a very apt way of describing their relationship. Okay, as Forrest Gump would say, that's all I'm going to say about that. Another fundamental thing to understand about the relationship between myeloid neoplasms are that all of these conditions arise from a single clone that attains a proliferative advantage. Now, the differences are that in AML, the cells don't mature. The blasts just proliferate and increase to the point that they completely occupy the marrow, and normal hematopoiesis is suppressed. In myeloproliferative neoplasms, the cells do mature and increase in one cell line. Now, this may, as we'll learn in an upcoming presentation, be the erythroid line or the megakaryocytic line, but most of the time it involves the myeloid line. And these, again, may progress to AML as they acquire additional mutations. And finally, myelodysplastic syndrome, the cells mature, but not very efficiently, and the patients end up developing cytopenias. So there's a defect in hematopoiesis. Okay, as I promised, one of the risk factors for myeloid neoplasms are the administration of genotoxic agents. And so these patients can develop therapy-related myelodysplastic syndrome and or AML. And some of the agents specifically at highest risk as a side effect for developing myeloid neoplasms are etoposide, topoisomerase II, type 2 inhibitors, alkylating agents, and finally radiotherapy. All of these have in common that they cause breaks in the DNA. All right, let's get into some pathology now. So AML, as I mentioned, is a proliferation of immature marrow cells we call blasts. Some of the different variants do show slightly greater degrees of differentiation, and then these cells again fill up the bone marrow and eventually spill into the peripheral circulation. So in general, our criteria for calling a myeloid neoplasm AML is that 20% or more of the bone marrow cells or blood, peripheral blood white cells are blasts. So we have to recognize what blasts are. Now, the classification of different AMLs has undergone tremendous revision in the last generation. So when I first trained, we learned the FAB classification. This was a consortium of French, American, and British pathologists who got together and looked at hundreds of leukemia cases and then classified them according to morphology. This was way back in the days. Yes, we had TV, but we didn't have molecular typing and we had some cytogenetics, but definitely not the degree of genotypic information that we have now. So fast forward to 2016, the WHO, World Health Organization, issued a revised classification of acute leukemias, And this incorporated not only morphology, but now various other modalities of looking at leukemia, such as cytogenetics, the clinical presentation, and molecular features. And so now we talk about AML with recurrent genetic abnormalities, AML not otherwise specified, AML associated with myelodysplasia-related changes, and finally, as alluded to before, therapy-related AML. So the classification becomes much more granular and complicated with incorporation of these other modalities. Your mission, at least for right now, is just to recognize AML and blasts and basically their general features. So what are the clinical presentations of AML? Well, probably the main clinical presentation are symptoms that suggest marrow failure. So this may be fatigue due to anemia, or bleeding due to thrombocytopenia, or finally infection due to neutropenia. Remember, the blast cells are crowding out normal hematopoiesis, so you may see different signs and symptoms of marrow failure. Occasionally, the AML may present as a mass, and we call these granulocytic sarcoma primarily for historic reasons. They are neither granulocytic because they're blasts, nor are they sarcomas because these are hematopoietic neoplasms. But the name has stuck, and occasionally these masses may present months before marrow and or blood involvement is evident. And finally, a high yield fact, we'll return to this when we discuss a little bit later, but AML with monocytic differentiation has a singular tendency for skin infiltration or to form a gingival mass at the same time that there's marrow and blood involvement. So that's an important high yield diagnostic feature that you can look for. Okay, so what are the general features of AML blasts? Well, first of all, they have, another thing to note is that these blasts are quite large. They really stick out in the peripheral blood. They're usually about 4 to 5 times the size of red cells that are next door. Most of the time the nuclei have a somewhat ovoid shape. Sometimes, as you can see, they're a little bit more irregular. Because the chromatin is fine and dispersed, you can recognize prominent nucleoli. There's variable amounts of cytoplasm. Oftentimes it's just a narrow rim. In other cases you see a little bit more cytoplasm like you see in these blasts. And it's usually pale blue in color, which reflects intense increased RNA synthesis. Now, sometimes you can see granules akin to the same type of primary and secondary granules that you see in normal myelopoiesis. And in some cases you can see structures that I'll show you in the when I talk about APL, which are called Auer rods. And these are intracytoplasmic needle-shaped red structures that have obviously a rod shape, and we see these in blasts and other more differentiated cells. Now, we use immunophenotyping to characterize these blasts. This is usually done by flow cytometry, and most myeloid blasts are positive for markers of immature or stem cells. So we look for positivity for CD34 and or CD117, also known as c-KIT. Now the exceptions, again, these are high yield exceptions, occur with APL and acute monocytic leukemia, which I'll talk about in a bit. Oh, hey, I'm talking about it right now. So these are the high yield AML subtypes. Acute promyelocytic leukemia, acute monoblastic and monocytic leukemia, and acute megakaryoblast leukemia. So let's talk a little bit about these guys. So APL is a medical emergency. It has a high rate of early mortality, which is often due to hemorrhage, which I'll explain in a second. And so it's critical that we as pathologists recognize when APL is present or even might be present, because it indicates that treatment needs to be initiated promptly based on morphology alone. We can't really wait for confirmatory cytogenetic or molecular testing. In addition, patients with AML in general and APL in particular present with symptoms, as mentioned, that are related to complications of pancytopenia, that is anemia, neutropenia, and thrombocytopenia. So this includes weakness and easy fatigability, infections of variable severity, and especially hemorrhagic findings such as gingival bleeding, ecchymoses, epistaxis, or nosebleeds, or menorrhagia in women. Combinations of these symptoms are common. Now, unique to APL is a presentation with bleeding, which is secondary to DIC. The coagulopathy that's associated with APL is complex and involves both DIC as well as primary hypofibrinolysis, and it is either present at diagnosis or occurs soon after the initiation of cytotoxic chemotherapy. This complication constitutes a medical emergency because if it's left untreated, it can cause pulmonary or cerebrovascular hemorrhage, which occurs in up to 40% of patients. This has a 10 to 20% incidence of early hemorrhagic death. Thrombotic complications occur but are much less common. I'll touch upon the treatment for APL because it's also unique among the acute myeloid leukemias. The treatment is all transretinoic acid, which is a vitamin A derivative, and instead of being cytotoxic, it actually causes the blasts to differentiate. So I'm sure you'll have much more about this in the pharmacology self-study material. Another thing that distinguishes APL is its morphology. APL is characterized by the presence of atypical promyelocytes in the bone marrow and peripheral blood. These promyelocytes are usually large, about 4 times the size of red blood cells, and these are still myeloid precursors, and they have a quite variable morphology. Usually there's a high nuclear to cytoplasmic ratio. The chromatin is still fine, however, and there's still recognizable prominent nucleoli. The cardinal feature of the promyelocyte is the presence of many violet primary granules in the cytoplasm. Now, these granules may either have a dense or coarse pattern, which often obscures the nucleus, kind of like basophils, if you remember. The cells of APL also differ morphologically from those of normal promyelocytes in that they are larger and typically have creased, folded, bilobed, kidney-shaped, or dumbbell-shaped nucleoli. The typical nondescript blasts that we see in other forms of AML are not found. So, in APL, we have these blasts with distinctive morphologic features. They have these bilobed, oddly shaped nuclei, and in this cell we can see the hour rods, these needle-shaped, dark purple or red rod-shaped structures. There is a microgranular variant, which is included for the sake of completeness, but please don't think that you have to distinguish between the typical and microgranular variants. That's not important. Important thing is to recognize that these blasts have these number 1, granules, number 2, hour rods, and number 3, these bilobed, creased, or other oddly shaped nuclei. Okay, the other unique thing about APL is its molecular hallmarks. APL is defined by the presence of a reciprocal translocation involving the long arms of chromosomes 15 and 17, which results in the creation of a fusion gene called PML-RARA, or RARA, which links the retinoic acid receptor alpha, or RARA, gene on chromosome 17 with the promyelocytic leukemia, that is PML gene, on chromosome 15. Alas, if it were so straightforward, but there are multiple variant translocations that involve the RARA gene on chromosome 17 that have been described that share the morphologic features of APL, but these cases have been reclassified in the current WHO system as AML with a variant RARA translocation because there is some variation in the biology of these APL variants, as well as differences in their response to retinoic acid. For your purposes, you need to know that APL is associated with T-1517, which results in the PML-RARA gene fusion, and just tip your hat to the acknowledge that there are some variant translocations, but the details are really too much for first-year medical or for preclinical medical students at this point. Okay, let's look at another high-yield variant. That's acute monoblastic and monocytic leukemia. In these leukemias, the marrow is composed of an admixture or a spectrum of cells showing differentiation between monoblasts, promyelocytes, and monocytes, and there is a minor percentage of neutrophils as well. So when most of the cells are monoblasts, we call that monoblastic leukemia. If there's evidence of maturation in which the promonocytes and mature monocytes are more prevalent, and less than 80% of the cells are monoblasts, we call that acute monocytic leukemia. So there's a wide spectrum, and sometimes it's somewhat a gray zone whether we classify it as one way or the other. Now, the key high-yield fact for acute monoblastic and monocytic leukemias are characteristic leukemic infiltration of the gums. I'll show you a picture to illustrate this in a second. The other unique thing is that the morphology is slightly different. So the monoblasts, as opposed to APL and in AML, in general AML, the leukemic cells have round nuclei and a lacy fine chromatin. Usually there's some small peripherally placed nuclei, and the cytoplasm is more abundant and frequently shows these small vacuoles, just like normal monocytes and macrophages do. Again, one of the key clinical findings in acute monoblastic leukemia is marked gingival enlargement, which results from leukemic infiltration of the gums. Okay, our final high-yield AML variant is acute megakaryoblast leukemia. In this leukemia, there's characteristic bone marrow fibrosis as opposed to packing of the marrow with blasts as in other types of AML. We see immature forms of red and white cells in the peripheral blood without splenomegaly, and we'll keep this fact in the back of our minds when we compare this with myeloproliferative disorders later on. Acute megakaryoblast leukemia is actually an uncommon form of AML and is less than 5% of cases. Again, the bone marrow is comprised of at least 20% blasts, of which at least half can be demonstrated to show megakaryocytic lineage by different markers. Bone marrow fibrosis and a leukoerythroblastic blood picture may be present. You can distinguish megakaryoblast from other blasts by virtue of either maturation to cells that resemble normal megakaryocytes or by special staining or immunophenotyping techniques with megakaryocytic markers. Now, a high-yield fact is that acute megakaryoblast leukemia in infants and children may be associated with the presence of a T122, as well as Down syndrome, trisomy 21. Now, in adults, there's a higher incidence of antecedent hematologic disorder, myelodysplastic syndrome, or prior chemotherapy. So in adults, acute megakaryoblast leukemia is more associated with some kind of therapy-related AML. All right, to round out this talk on acute leukemias, we'll turn to acute lymphoblastic leukemia / lymphoblastic lymphoma. Now, why does this have two names? That's because ALL and LBL constitute a biologic spectrum of neoplastic lymphoid disorders characterized by the proliferation of immature blast cells of B cell or T cell lineage. Now, for clinical purposes, an arbitrary cutoff has been used for many years to separate lymphoblastic leukemia from lymphoblastic lymphoma. So cases in which there is 25% or better of marrow replacement are designated as ALL. Cases with tissue involvement and less than 25% replacement of marrow cellularity by lymphoid blasts have been designated as lymphoblastic lymphoma. ALL can occur at any age, but most cases are in children, and it constitutes the most common type of childhood malignancy. The disease actually, though, has a bimodal age distribution. There's this higher incidence peaking in early childhood with a median age of 4 years for B-cell ALL and slightly older at 10 years for T-cell ALL, as well as a second lower incidence peak that occurs in older adults greater than 60 years. Similar to AML, most patients have findings that are associated with anemia, neutropenia, and/or thrombocytopenia due to bone marrow involvement by blasts. The white cell count may be actually decreased, normal, or markedly elevated. Symptoms are associated with marrow replacement by blasts and include fatigue, infections, or easy spontaneous bruising or bleeding. Bone pain or arthralgias may be prominent complaints, and you may see constitutional symptoms such as fever, night sweats, or weight loss. Hepatomegaly, splenomegaly, and/or lymphadenopathy are present in up to half of adults. Central nervous system involvement may show up as cranial neuropathies or meningeal symptoms, and this is something that characterizes ALL from AML generally. B-cell acute lymphoblastic lymphoma has a characteristic presentation in teenagers as an anterior/superior mediastinal mass. It has the exact same morphological, immunophenotypic, and molecular abnormalities as BLL. We just call this lymphoma because the lymphoblasts form a mass, hence the oma at the end of the name. So with BALL/LBL, the most common cytologic appearance of lymphoblasts are that they are small to medium-sized round nuclei. Notice that these blasts are a little bit smaller than AML blasts, maybe 3 times the size or so of surrounding red cells. They have scant cytoplasm. They shouldn't have granules, really. They have a more open chromatin pattern as compared with small mature lymphocytes, and they generally have indistinct nucleoli. Occasional blasts can have cleave or folded nuclear outlines like you see in some of these cells. Now we can use some different markers to characterize ALL by immunophenotyping. By definition, lymphoblasts express terminal deoxynucleotidal transferase. 10 points if you can say that, or TDT. B lymphoblasts are characterized by markers of B-cell lineage, including CD10, CD19, and CD20. T lymphoblasts, on the other hand, express a variable combination of T-cell markers, which are listed here, but importantly, they do not express CD10. Now, while T-ALL lacks characteristic molecular hallmarks, we can recognize some molecular hallmarks of B-ALL. First is a translocation between chromosomes 12 and 21, which results in the fusion gene ETB6 run X1. This is the most common chromosomal rearrangement in childhood, BLL, BALL, but it's rare in adults, and this translocation confers a good prognosis. Now, another molecular hallmark, which is more characteristic of myeloproliferative neoplasm, especially chronic myeloid leukemia, which I'll talk about in another presentation, is the T922 translocation, which is the Philadelphia chromosome. Now, this is a much more common molecular change in adult BALL, and it confers a poor prognosis. All right, so that's enough about acute leukemia. Let's just briefly recap. Acute means immature precursor cells, not necessarily clinically acute. We can distinguish between acute myeloid versus lymphoblastic leukemias. There's a couple special types of AML that have some characteristic clinical and or molecular and morphological features. And then finally, we have acute lymphoblastic leukemia / lymphoblastic lymphoma, and we characterize whether these show features of B cell markers or T cell markers, and when these cases predominantly present as a mass, we call that acute lymphoblastic lymphoma. All right,